Thank you, all of you. I really want to jump into sharing some things that I think will give you a greater degree of certainty and what's happening in the field more broadly in behavioral health, but also continual uncertainty. I think that's the name of the game. As we have to make decisions and pivot again, and also we'll still see some changes happening. So I will give you the up-to-date what's happening right now, how we're addressing it in the office, what to expect, and then some anticipated future projections of things that we will face at Psychology Specialists of Maine, and some things you might be interested in knowing that are happening more broadly in the behavioral health field. So I do have a slideshow that I will share, and hopefully have some time for questions or comments in the end, but also if you have anything that you want to ask me as I'm presenting, please just chime in and unmute yourself. So my focus today is a little more to ground you in how Psychology Specialists of Maine in particular is going to be responding to some of the changes as we transition to offering some in-person sessions, what that looks like now, really as of what I'm considering August 2021, and how that might look well into the future. But I do want to address, like I said, some of the broader changes in behavioral health and what we're going to see rolling out over the next few years, and changes that have happened really drastically as a result of the pandemic. Just a nod to, obviously, we all know March 2020, we all left the office along with most behavioral health professionals all across the nation. Telepsychology became the primary modality for psychotherapy, and I think many of us were pleasantly surprised at how effective it was. A lot of research is being done that shows a high level of efficacy for telepsychology across most client populations. And so that's very promising, and we will not see this go away, and we will see it expand. So I'll talk about some of the things that are changing on a legislative level. And certainly at Psychology Specialists of Maine, one of the things we did in 2020 is really sort of solidify and create a fully remote telepsychology team of therapists. Right now we have 5 psychologists who are fully remote, and we'll be adding 4 more over the next couple of months, some of whom are our postdocs now. So our telepsychology team sees as few as 6 clients a week up to a full caseload of 25 clients a week. We are a paperless office, which actually happened in January 2020. So we were well positioned to transition to fully remote office. That went very smoothly for us. I think, as you know, inevitably we have some technical challenges, and that's been something we're just used to, and have backup platforms and things to accommodate clients. But for the most part, we've been able to continue to work seamlessly. We've seen fewer cancellations, some of the convenience and benefit of being able to do sort of remote therapy. Our administrative team is remote. As you know, Valerie transitioned out of the office along with us in March, and actually now lives in New Hampshire. We realized very quickly she could do her job extremely well and efficiently without being in the office. And she's taken on a leadership role when we hired a part-time administrator, Nicole, who has now taken over all of our claims and billing. So that's been a huge help to Valerie, who's primarily responsible for clinical coordination and does a lot of data analytics and helps with payroll for the office. But I'm really happy with the remote team, and I think that's pretty much the new normal. I don't anticipate having any administrators in the office or in need for one, because things have changed, and I'll talk about the client experience today as well. In-person sessions versus online, we're going to get to this, but of course that's going to be, those of you, for example, who know you're going to be in the office, say on Tuesdays and Thursdays, my primary thinking is always psychologists first, then clients. I know you take superb care of your clients, so then I just think about how do I take mindful care and create the best work environment so that psychologists can thrive and do their best work. So offering the option for you to work from home on the days you prefer. And then when you're in the office, it's really going to look like those are the clients for whom you offer in-person sessions initially. Some of those clients will gladly come in and meet with you in person. Others are going to opt to continue to meet remotely. So I'll talk about how we have all the offices that will be set up for both remote and hybrid work, remote and in-person work. You may have a 10 o'clock coming in the office and your 11 o'clock is going to be online. That's going to be an adjustment and a shift for us. And we'll have to see how that feels. But the idea that Lauren's going to be sitting there with all her sticky notes, I'm not expecting you to initially accommodate client preferences, nor can we for some reasons, and I'll talk about those. But the idea is the days you're in the office are the days you can offer in-person sessions to clients. And there's another sort of caveat to that right now, because we're following APA guidelines. You're going to offer those in-person sessions to clients whom you deem it clinically necessary. And I'll talk about the criteria for clinical necessity today as well. A lot of things have changed in behavioral health over the past year and a half. We've seen a lot of interest from private equity companies and what we do, and capitalization on therapy is occurring at a really rapid rate. So you look at things like BetterHelp and Talkspace and these other larger organizations that provide text-based and email-based therapy. Just a lot of interesting things going on, and we might see that go to one day soon. You're going on Amazon.com to find a therapist, and I'm not kidding when I say that. We have a really unique model at Psychology Specialists of Maine. There are very few behavioral health private practices that are all doctoral level. So we're not seeing the same kind of competition as other group practices that focus on mid-level therapists. And so we have not been impacted by that from a hiring perspective. Psychology, our office almost doubled from 2020 to 2021 projections. I'll talk about SciPact. That's a new thing for Maine starting in September. And I have a slide to talk a little bit more about that, but I did let everyone know that legislation was approved by Governor Mills to join SciPact, and that starts way more quickly than we anticipated. So just 2 to 3 months from now. I think I've addressed all of these things. Some of the other ways we pivoted this year, of course, all of our staff psychologists became remote. We developed a telepsychology affiliates team. We successfully trained 4 postdoctoral residents remotely, which I'm really proud of. And I think last May 2020, I didn't even think it was possible, but Kate and I just said, we're doing this. We don't have a choice. And there's some things about it that actually were very favorable that we will continue to do. Our clinical training webinars, we did cancel a few, but we had 2 successful online webinars and people really appreciated that format. We had a lot of mental health professionals from quite a distance be able to join our training. And there seems to be interest in continuing that to some degree. All of our staff meetings went online. Things like being able to record our lunch and learn workshops was great. So those are all on our website and accessible to other behavioral health professionals. People seem to appreciate that. We started our listserv and newsletter and found ways to stay connected as much as possible while we were all working remotely. I will say it's been really great seeing people in the office. That part I missed the most. So I focused on kind of bringing our work culture back. I want to move into talking about my considerations when I think about in-person treatment and how we're approaching this, and really thinking about what are the APA guidelines, what are the CDC recommendations, what's the state of Maine saying. So right now, the APA came out with recommendations and addressed these questions about for whom and when do we offer in-person treatment. They had originally published an article in March and they updated it in May. I'm looking regularly for more updates. It makes sense to me they're going to continue to make the same recommendation as we're seeing sort of the Delta variant outbreak And as Sue mentioned, we are still, in the middle of a pandemic, with the understanding that the vaccine is very effective. Of course, not for 100% of people. So that's something that we want to keep in mind. The APA recommendations are, if you are offering in-person treatment, then you want to require clinical necessity. I'm going to talk about the criteria they suggest for clinical necessity, so that you can begin thinking about that. It's fairly broad. And then I just ask that if you deem it clinically necessary to see a client in person, that you just document the rationale for that on that particular note. We do have an in-person consent addendum, which was also recommended by APA, that is sent to all clients who are going to be entering the office. They sign that electronically and it's uploaded into their documents. You should, again, once the client is in the office, discuss any risks with the clients. We will have signage in the office, and I'll talk about some of the other mandates we have established for any clients who are coming into our office space. For that, I'm really looking at the state guidelines and the CDC guidelines, which I'll share next. This is the APA's clinical necessity criteria, asking yourself questions like, does your patient have access to a telehealth platform? Are they able to use it? Michael pointed out some people don't have privacy. That would be a consideration. Other people may really struggle with bandwidth, and you're having a hard time with that particular client really having sort of smooth therapeutic interaction. Anything related to the telehealth portion and technological difficulties could be included under clinical necessity, as well as privacy issues. If it's ongoing treatment, asking yourself, is the client making progress? Do you think that the online therapy is a barrier to progress? Is there a decline in treatment outcomes? Those are things you would want to consider having the client being seen in person. Consideration of the next phase of treatment, whether or not it's appropriate and helpful for that client to continue to work remotely, or does it require face-to-face contact? If you ever have questions, then you could, consult with myself or Kate to ask about whether or not you feel like, a client meets clinical necessity, but I'm going to say it's fairly subjective and you're going to use your clinical judgment to make those decisions. If you feel like the treatment's going really well with the client, there are no technical issues, and you have a client who has a strong preference and they're really pushing for in-person treatment, APA did sort of make a statement that you want to be cautious. And, I guess if you're in a situation where they're really dissatisfied for whatever reason, then you might be able to make an exception for preference. But again, you have to sort of document the conversation you're having with clients about risk of coming into the office, for example. We are doing everything possible to minimize any risk of viral transmission in our office. I looked at, every state has different laws. Maine does have a law that businesses and organizations can mandate vaccinations. I've decided that we are mandating vaccinations, but very careful not to sort of be doing this in a discriminatory way. So if you have a client who, is not vaccinated, then we would continue to offer telehealth as an alternative to in-person treatment. Again, because we're confident about the efficacy of this treatment, that feels appropriate, as that's the option for someone who's not vaccinated, so that we minimize the risk to our staff and to other clients. If you were to have a client who's unvaccinated and you feel like it's clinically necessary, then we have to talk about referring to a therapist who's offering in-person treatment to unvaccinated clients. I think we're just going to draw a very clear line rather than moving to the idea of sort of social distancing and masking during sessions. Because we know telehealth is an effective alternative, that's what will be offered to clients who are not vaccinated. I am not at the point where I'm sort of requiring the sort of level of administrative work it would take to ask for vaccine cards. But if you have any concerns about that, this would be something you are going to, either already know or have a discussion with your client about. And then we would I think it's safe to assume somebody's going to be upfront and honest about whether or not they've been vaccinated. And the definition of vaccinated, fully vaccinated, would be that they have had 2 administrations of the vaccine, and they are 14 days post that second administration. There's some question, right? This is the gray area about whether or not people are going to need boosters and what that's going to look like. Again, I think we're just erring on the side of caution in how we're moving forward with this. CDC guidelines are suggesting that they're recommending that people wear masks in healthcare settings. You'll notice if you go see your primary care physician or you're in a hospital, masks are mandated regardless of whether anyone's vaccinated. They're certainly not looking at vaccination status, but they're still taking temperature checks. Given that we are going to require vaccinations, we are not going to require masking during therapy sessions. I am erring on the side of caution and requiring that all staff and clients do mask in common areas, such as the lobby, waiting room, and ideally that they don't arrive more than 5 minutes prior to their session. So there's no one sort of lingering around. And that really is a nod to the fact that the data suggests that the vaccines are 95% effective. So it feels like the responsible thing to do, that we are requiring masking. And it also respectful of people who have more anxiety or health issues and very concerned about being exposed even around people who are vaccinated. So that's what the signage will say as well. To our consent form, our normal service agreement that we have online for clients, I've added this statement so that everybody who is electing to have what will be a telehealth intake will read the statement that decisions related to providing in-person services instead of telehealth are made by factoring in clinical necessity and possible risk for specific patients and clinicians, and are made on a case-by-case basis. Really, you as the therapist have the autonomy and ability to make those decisions about clinical necessity. So we're not going to initially offer intakes as in-person, although it's certainly something we could start doing if Valerie's screening for intake and we learn that the client is vaccinated and they're having an intake on one of your in-office days, then certainly makes sense that we could offer that but it's really tricky around the clinical necessity piece, if that makes sense. So we may not initially roll that out. Some of the in-person session policies, again, therapist driven. It's a hybrid model. I anticipate, this is on another slide, but the official start date for our office matrix is August 23rd. I picked that date because it's essentially the start of a new year for our training year. That's when our new postdocs arrive, and they'll be in training actually that Monday. But if you say are in the office Tuesdays and Thursdays, you could decide on August 23rd, you start offering that. If you have clients where you feel like you want to have that conversation about in-person sessions being more helpful because of clinical necessity, and you may decide you're going to be in the office and be part of our kind of return to office culture, but that maybe you don't have any clients who meet the criteria for clinical necessity who you see on those days. Or you are, if that's the case, then you're going to be doing telehealth from the office on those days. That's fine. There's never any pressure from me. And certainly if we're following APA guidelines, there's not any pressure to sort of bring clients in based on preference, yours or theirs. It really should be based on clinical necessity. Again, documenting that is just in the note. And you'll also notice that location is going to change from telepsychology to in office. So you'll want to try to remember to change the location for clients who are coming in the office on the therapy notes document.
Julie, I have a quick question.
Yes.
If for some reason at the end of August, when we start going according to the calendar, if we can't come in, or, like if my daughter's sick and I'm trying to do remote work on that day, is that okay? And should we let you know or do anything in that case?
Yes. And let me just go to that slide really quick. So this is the grid that we created based on my survey of all of you of the days you preferred to be in the office. You'll notice in some cases we're doing office sharing because it just makes good sense. If you know right now you've changed your mind, or you are probably only going to come in one day, it's really helpful for me to know that. I'm happy to make that change, but it does have implications for how we think about office use. I'm putting this as August 23rd to March 31st, which is like somewhat arbitrary, but it's 7 months. It just gives us some to anticipate. On an occasional basis, if you're not going to come in, that's totally fine. But if you know you're never coming in on Tuesdays and you're on the Tuesday, that would be helpful for me to know. So good question. I think all of our staff were pretty eager to be vaccinated last January. It's not sort of a requirement I made of you, but at this point, if somebody had, like, I don't know, decided not to get vaccinated for any reason, you would want to let me know that in office wouldn't be an option for you in terms of seeing clients. The idea that masks are not required in session, I guess if we want to get really down to sort of data, there's, Kelly's point about having kids younger than 12 who aren't vaccinated. You're in a room with clients who have been vaccinated, you're unmasked. We know that the CDC is saying that that's safe, very unlikely transmission, but that small percentage, if that gives you pause, means some of the things we're doing are bringing in air filtration just for that other layer of caution. But if you have personal reasons why that still feels like a risk to you, please talk to me about it. And if you don't have clients for whom you think it's clinically necessary to see them in person, that's certainly not a requirement. All clients who are being invited in by you, the easiest thing to do is for you to just send them the link to the in-person consent form. That's very easy to do. I'll give it to all of you. It's also on our website. If you just want to direct the clients to the client forms on our website, they could very easily find this and sign it. And it will be uploaded into their documents. There will be signs in the office. We do have medical masks available for clients who enter and they don't have one, or if you want to use the medical masks we supply, you can feel free to do that. We'll always have them in the offices. So I think that covers all the logistics. That's actually a photo of the sign that we have. This is the middle thing is the in-person addendum. And then the service agreement changes. Obviously, I know you can't read this, nor do you need to, but if anyone wants to see the PDF version of our online forms to just see what the clients are reviewing, I'm happy to send you those. And I think I will just send everyone the PDF informed consent for in-person services, just so you can review that and be familiar with what's on there, because it's a good idea for you to go over that with your clients as well. So some of the changes that have happened when you come back in the office, of course, we always occupied suite 309. And now starting last year, we took over suite 310, which is across the hall. The sort of pre-COVID flow was that we really liked people and new clients to come into 309 because they would sort of check in with Valerie. With offsite administrators, we don't have kind of a primary suite anymore. We've added suite 308, which has 4 therapy offices. And so my plan is we have now an open doorway between 308 and 310. So it's really essentially one big office suite. Clients will see when they enter our office, Psychology Specialists of Maine, on the door of 309 and the door of 310. And they can, our names, according to which suite we're in, will be on the outside of the door. So when they're intake is confirmed, this is sort of more in the future. For new intakes that are coming in, they will be provided very clear information about the therapists they're seeing and the suite the therapist is in. But you can have that discussion with the clients that you're inviting in, and it will be very easy for them to navigate and know sort of where to go. If they have questions about billing, they just simply make a phone call or send an email to Valerie rather than speaking with her in person, or Nicole in the case of billing. So that is, I will say, like something I've grieved and come to terms with, that when we come back, we will all really miss seeing Valerie in the window. But a lot of changes have happened, and we know how accessible and helpful she is. And having Nicole has really been so necessary. And I'm reading more and more on the MEPA listserv about difficulties in collecting from insurance companies. And it is true to some extent. There are just some interesting new obstacles that behavioral health offices are facing, and we are nearly 100% collections because we can be so on top of things, which is a really good thing. And part of that is because if anything doesn't get paid, we have Nicole to chase it down. So our administrative team is remote. Clients will have signage on knowing exactly where to go. I don't anticipate any problems with that. We are comfortable going to greet clients when they arrive, so that will continue. There'll be 2 lobby areas, 1 in each suite. All the offices will be set up. We're rearranging furniture, so essentially all the desks are facing windows because it's much better for telehealth. You'll have also laptop stands. If anybody wants a standing desk fixture, let me know. Ron mentioned that that's something he would find really helpful. I'm happy to support that, as well as ring lights. So once we do face those winter months coming, you'll need those for your online sessions. So it should be easy to navigate both online and in person. And that is that. All right. Some of you mentioned anxiety, uncertainty about how it's going to feel to be sitting with clients. A lot of us are going to be meeting clients for the first time. And it's really important that, we can help clients anticipate maybe their own emotional or intense reactions that might emerge as part of meeting us in person, as well as have a space for us to process our own reactions, expected and unexpected. And I think, I think Ron mentioned that, we will very probably quickly slide right back into what's been so familiar to many of us for decades. But initially, it's a very new phenomenon to have a therapeutic relationship with someone whom you've never met in person is a new thing for us. So it's nice that it coincides with one of my goals was to offer another consultation group that was focused around self of therapist, which really opens us up for less sort of a clinical focus and much more focus around countertransference and our own reflections on our work with clients. So our first meeting will be Monday, August 30th. And just sort of broadly, the felt experience for us as therapists as we have some initial sessions with clients in person. And then we will continue this consultation group on the 3rd Monday of each month from 12 to 1. That brings me to another kind of difficult thing of how are we going to do our meetings? And I think it's nice to be able to meet in person, but not everybody can meet in person. So we are actually the very large 2-window corner office in 309 is being transformed into both a group therapy room and a staff consultation room. There's a large TV in there. So all of our meetings will then transition to a hybrid format. So those of us who are in the office on Mondays can meet in person, and everybody who's not in the office will appear on the TV so we can see them, and then they can see us. I'll set it up so that, it's an as ideal as we can be, but that's a new thing and we'll be getting used to that. But that could be for brown bags, for consultation. And I think because we have a growing remote team of therapists, we'll have separate opportunities as well for remote team consultation meetings, and really focus on creating a whole work culture around telehealth, so that there's a sense of connection and camaraderie and consultation. And there's lots of ways we can do that with listservs and webinar style meetings. So that being said, you might have noticed on our office grid that pretty much our office is like closed to in-person sessions on Fridays, and our new postdocs will have Fridays for a lot of their didactics, and we'll just make that their primary non-clinical day. So if anybody did want to consider, office space, Fridays are pretty much wide open. So a couple of things I wanted to mention about the future of behavioral health. Of course, telehealth is here to stay, and it's got a pretty strong hold. A lot of you are noticing there'll be a fair number of clients who just simply find it more convenient to meet via telehealth. I anticipate there will be sort of three groups of clients: those who want to do all their therapy remotely, those who want to do all their therapy in person, and those who want to see you once in a while in person, but take advantage of the convenience of remote options. So the question is, what percentage will we see in each of those categories? So there's been some speculation. I last talked to someone last summer, but they were using models from Silicon Valley and California that were already adopting sort of a 50-50 hybrid model of telehealth and in-person. And so I would say last summer, I was anticipating like, gee, we're probably going to see 50% of our clients want to continue telepsychology and maybe 50% coming in person. As time has progressed, for me, if I had to wage a bet, I would say we might see 30% of our clients want, routine in-person therapy. And a percentage of those will miss in-person sessions in favor of the convenience of telehealth. I don't know, though. I don't have a crystal ball, and I'll be very interested to see. I think those of us as therapists who are very comfortable with telehealth will see a higher percentage of our clients who are also very comfortable with telehealth. Those of us who are very eager and give preference to in-person, we are probably going to see a higher percentage of our clients wanting to come back. And, it suggests we certainly have an influence on client preference, and that's okay. I mean, that's just, to me, part of what's going to happen. So SciPact is a telehealth, well, let's see, how do I say this? Historically, there started to be discussions as early as 2011 about interstate practice, and now we're really bumping up against it in a serious way. We've all learned that every state has different rules and laws around allowing psychologists who aren't licensed in their state to practice telehealth. We've been able, through COVID, because of the public health emergency and the loosened restrictions, we've been able to get temporary licenses for the clients we were seeing who moved out of the state of Maine. We were able to get sort of a limited number of sessions. But once the public health emergency ends, you'll notice there are some states that offer no flexibility. We're not able to see clients who aren't, physically located in the state of Maine. And this is a good opportunity just to remind you that the licensure in Maine really has to do with, if you're licensed in the state of Maine, you can see clients who are physically present in the state of Maine. So it actually doesn't matter where you are, which is why, we have a couple of therapists who are not in the state of Maine, but as long as they're licensed in Maine. The first state to join SciPact was Arizona in 2016, and a few others quickly followed. I think a year ago, there may have been 15 states that were part of SciPact. And basically that allows psychologists who are licensed in a state that's a member of SIPAC to get what they call a passport. And you can apply for either a temporary passport that would be adequate for you, providing sort of transition sessions for clients moving out of state, or you can get a telepsychology passport that allows you to practice telepsychology in any of the what will be 25 states that are a member of SIPAC. So, where we are right now, that just makes it a lot more easy and convenient for some of our clients who are located in states that will be members of SIPAC, and we can make decisions about, whether or not we want all of our psychologists to be registered, some of our psychologists, and then where is the sort of value for Psychology Specialists of Maine in being able to offer telehealth to clients across this in 25 states. We have a tremendous wait list. We're trying to keep it to just 50 clients. And we actually made some efforts to get fewer referrals at a point in time when we were feeling really flooded with like 350 referrals in 1 month. So the idea that we would really want to serve anyone out of the state of Maine isn't neither necessary or appealing. We really want to help Maine clients. And yet at the same time, it presents opportunities for us to offer some of our harder to find services. Like we're getting a lot of requests for our DBT groups from out of state clients. But we're also trying to be innovative and think about, wow, okay, so the future of behavioral health is looking like teletherapy isn't going away. It's increasing, it's decreasing stigma, it's increasing access to care, it's increasing convenience, decreasing barriers. So how do we utilize this to really make an impact on the field? And so one of my interests for a long time has been college counseling. We obviously serve a lot of students now. College counseling centers for well over a decade have been struggling with how to accommodate the increased demand among college students for services. And so I think we're going to see people addressing that with telehealth options. Our idea was to beta test for this year college student services, basically by reaching out directly to college counseling center directors in the state of Maine, as well as offices that serve clients who have, I don't know the proper name, disability, ADA related concerns, and, trying to build alliances with these schools to provide options for credible expert psychologists who have expertise in areas most sought out by college students. And so we've actually developed a brochure with the help of our undergraduate intern who is a Bowdoin student. And she's been really helpful in helping us think through how this could be impactful. Because our group program is growing, primarily we have 5 DBT groups now. Lauren is launching her college student ADHD skills group in the fall, and Michael plans on 3 interpersonal process groups. So I see us becoming a site that's well known for group therapy options, and we will certainly offer some of those online. The idea of college therapy specialists would be this would be a fully online resource, starting out with the Maine students, but then being expanded theoretically to students in 25 states if we were to build alliances with colleges. There are lots of ways to do that. So that's exciting, but we'll just see how that goes in Maine to start. Okay, this is the Q&A portion. I'm going to stop